Good afternoon, all. First topic is unraveling the reversibility of the pulmonary vascular disease in congenital heart disease, and the topic and the speaker is Dr. Shangita Vishwanathan.
Thank you so much for this opportunity on the Vishwa Bandyopadhyay Hall. So the first disclaimer I have to make is that I don't have any pharmaceutical disclosures, but I'm also not a domain expert in pulmonary hypertension. So like many of you in this hall, I'm a practicing clinician who comes across many patients with pulmonary hypertension, where I have questions about operability and whether this pulmonary hypertension is reversible at all. So when we, just to clarify some terminology, when we say operability, I guess we mean, will this patient, survive surgery and perhaps be discharged home after surgery? When we talk about reversibility, we talk about the pulmonary hypertension regressing to normal value. So there's a slight but subtle difference between the two. Can I just move the slides like this? Perfect. Thank you. So pulmonary hypertension is a kind of, in congenital heart disease, is a kind of a unique subset of pulmonary hypertension. And the reason that I say that is it offers you the opportunity to see the progression of the disease, through its natural history. In many other subsets of pulmonary hypertension, by the time the patient has presented to you, often the patient is in quite advanced pulmonary hypertension. But in pulmonary hypertension CHD, there is a sequence of events that you can follow as you trace the course or the natural history of this pulmonary hypertension. So in PAH-CHD, there is a known trigger. The trigger is quantifiable. The trigger can be removed. Once the trigger is removed, you see that in a timely fashion, the disease can reverse. And if you don't remove this trigger in a timely fashion, it becomes irreversible. There's also a subset of patients, you may remove the trigger in a timely fashion, but yet the disease progresses. So this condition allows you the opportunity to perhaps study the mechanisms involved and maybe target these mechanisms as possible therapeutic targets. So, I'm sure all of us are familiar with this kind of a chart where there seems to be a point of so-called no return. But this point of no return as well, I think kind of shifts, because now with the new therapeutic modalities that we have with us, what we may have considered inoperable or irreversible may indeed be operable and possibly reversible. No talk on pulmonary hypertension and reversibility is complete without a slide like this, which shows you PAH pathogenesis. I won't delve very deeply into this because I'm sure many of you are aware of the pathogenesis and can read it up in a textbook. But essentially, there are early pathological changes and late pathological changes as defined by lung biopsy. And there is an interplay between the flow dynamics in the pulmonary vasculature and the histopathological changes. And it is the flow disturbance initially that actually initiates this entire cascade of events that eventually leads to loss of peripheral vasculature and dilatation of the proximal pulmonary arteries. Now, if we look at practical management of patients with PAH-CHD, that is patients with congenital heart disease who have pulmonary hypertension, we all follow an algorithm somewhat like this. So it's a comprehensive assessment. No one tool is going to actually give us the answer about reversibility. And this comprehensive assessment relies on the clinical features, the basic investigations like echocardiography, chest X-ray, and ECG. And then once we have formed an impression as to whether this patient is clearly operable or clearly inoperable or somewhat borderline, we may decide then to proceed with cardiac catheterization. Cardiac catheterization is considered the cornerstone of this assessment of reversibility and operability that we carry out. Now, different algorithms have different cutoffs for reversibility. And here I'm talking about the left to right shunts particularly. So the more, the more conservative algorithms would consider a PVR less than 4 to be operable, more than 8, to be possibly inoperable, and 4 to 8 to perhaps be the gray zone. And this kind of more stringent criteria perhaps should be applied to older patients more. That is, the older the patient is, I think the more stringent the criteria are likely to be. There are other algorithms where up to 6 is considered, a PVR up to 6 is considered to be operable, and the criteria are less stringent. Again, acute vasodilator testing has been incorporated in some algorithms, but as you will see, not much of what we do is actually supported by any good literature. So there is really no gold standard for reversibility assessment. We've talked about this already, so I'm not going to repeat it. Just a specific mention about the single ventricle scenario is slightly different. So there we tend to rely more on the transpulmonary gradient, and the criteria that we use are slightly different from what we would use in a left to right shunt. So a transpulmonary gradient of less than 6 is reassuring, with a PVRI of maybe 3 Wood unit, less than 3 Wood units per meter square. As far as acute vasodilator testing is concerned, I mean, this is probably very basic for some of you, and maybe for the younger members of the audience useful. Either oxygen or nitric oxide is used, nitric oxide being considered perhaps a better agent to use. And a response is defined as a more than 20% fall in the pulmonary arterial pressures. And ideally, you want this response to reach a level of PVRI less than 6 and a vascular resistance ratio of less than 0.3. But in spite of all these very nice criteria that we have defined for ourselves, the sad truth is all of this is purely based on expert opinion and not on any robust evidence. There are no prospective studies that actually link these PVRI cutoffs with long-term outcomes in patients with congenital heart disease and pulmonary hypertension. So the same applies to acute vasodilator testing, balloon occlusion, etc. Now, we've always considered lung biopsy to be a histopathological gold standard, but as you all are aware, it is not very commonly performed. There is a significant morbidity and mortality associated with it. Plus, sampling is an issue because pulmonary vascular changes can be patchy in nature. And traditionally, by the histopathological classifications, changes, early and late changes have been demarcated. The early changes being things like medial hypertrophy and mild neointimal changes, and the late changes being severe fibrosis and plexiform lesions. However, there are studies that have shown that particularly in the younger patients, even the so-called severe changes on lung biopsy are reversible, either when the shunt is corrected or when a PA band is performed. Also, there are studies that show that just because you have early changes, it doesn't mean you're going to survive and have a good outcome. In fact, the early post-operative hypertensive crises that we see, these patients often have only early pulmonary vascular changes. They have only medial hypertrophy. So just because you have early changes on lung biopsy, you still need to be guarded about your outcomes, particularly in the early post-operative period. So, at the end of these slides, it seems like both our hemodynamic testing and our lung biopsy are filled with so many caveats and inaccuracies that we really aren't much further on in terms of our understanding of reversibility. So this is a paper that I came across recently. Some of you may already be well familiar with it, but although it has only a few patients enrolled in the study, I think it's quite a neatly done study that actually tries or makes an attempt to correlate the cath data, the lung biopsy data with some early outcomes, both just immediate post-op outcomes and outcomes at least 6 months of age. And this study basically uses pulmonary vasodilator therapy as well, and particularly seems to target that gray zone of patients between a PVRI of 4 to 8. So they picked up high-risk patients, high risk being defined by certain characteristics like age, whether the genetic syndrome, baseline saturation, absence of features of congestive heart failure. And these high-risk, patients, they subjected them to clinical evaluation, echocardiography, cardiac catheterization to assess their operability status. So there are 33 CATs that were done. Of these, they declared 3 of them inoperable based on the data, and that was based on the age. These were children with advanced age, and they had quite high baseline PVRI as well. The patients underwent not only CAT data collection at baseline, but also with nitric, which was given for about 10 minutes, and data was collected. They identified the responders, so-called responders to nitric, and these were 22 patients. So 11 of them did not respond. They didn't care whether the patients responded or not. Apart from the excluded 3 because of very high baseline PVR, they put all 33 forward for surgery anyway, irrespective of whether they responded to nitric or not. If you notice, even amongst the responders, there were some which didn't actually meet the criteria of PVRI less than 6 or PVR-SVR ratio of less than 0.3. So once the cath was done, these patients actually being already in the borderline group were started on pulmonary vasodilator therapy, and they had about a month's sildenafil before they went for surgery. Just the logistics of the whole process. This was actually okay. So once they started the sildenafil, they noticed in some patients that they developed symptoms of congestive heart failure. Their X-rays showed pulmonary congestion, all of which were positive signs, and they kind of immediately took these patients up for surgical correction. At the time of surgical correction, they managed to get open lung biopsies on 24 of these 30 patients that they operated upon. Okay, so out of the 33, 3 were excluded, 30 were operated, 24 had lung biopsies. So this image on the top shows you the effect of sildenafil. Just after 2 weeks of sildenafil, one of the patients developed a significant degree of pulmonary vascular congestion and was taken up for surgery. So what they found in the early results was they had 3 patients who died and 1 patient who had to go on ECMO. Now, of these 3 patients, interestingly, like we discussed earlier, the early mortality does not really correlate well with the advanced pulmonary vascular changes. So these 3 patients actually had a fairly acceptable baseline PVRI, 3.5 to 5. So not a very elevated PVRI. And when they had vasodilatory testing, they had a PVR-SVR ratio which was within acceptable limits. So one thing to note is the immediate postoperative mortality didn't seem to correlate with either a very high PVRI or an elevated PVR-SVR ratio. And again, in these patients who died, they found that the pulmonary vascular changes were actually not that advanced. So they were all mostly patients with medial hypertrophy. Now, at 6 months, these patients who had undergone surgery and survived, that is 27 of them, they recatheterized all of them to see what their now their PA pressures were and what was their PVR-SVR ratio. They found that at 6 months, 5 of the so-called non-responders had more than 30% increase in pulmonary blood flow, having with the sildenafil, and 7 of the patients who had high-grade lesions had a significant reduction in PVR and PA pressures. 12 patients continue to have elevated PVR and PA pressures, but this had dropped from the baseline. So, what I gathered from this study is, although we hold cardiac cath and biopsy to be kind of gold standards in our assessment, they don't, when you look at the clinical outcomes, they don't seem to correlate that well with the clinical outcomes, in this very small, I admit, but somewhat prospective study, which was attempting to look at outcomes and correlate them with the hemodynamic and lung biopsy features. Then they looked at those patients who had persistent pulmonary hypertension at 6 months, and those that had pulmonary hypertension that had resolved, and tried to see what are the characteristics in the persistent pulmonary hypertension group that can be identified as risk factors. So these are the only two factors on multivariate analysis that they could pick up. One was a pre-op PVR SVR on nitric of more than 0.24. So if a patient had a PVR SVR ratio of more than 0.24 on nitric, then these patients appear to be at risk of persistent PAH. So perhaps a cutoff of 0.24 on nitric was a risk factor for persistent pulmonary hypertension. Then on lung biopsy, they actually, in addition to grading using the traditional methods, they also measured the arteriolar wall thicknesses. And they found that the respiratory bronchial arteriolar wall thickness, the thicker it was, it seemed to have a protective effect in terms of long-term pulmonary hypertension. So, something like this in a larger scale may perhaps give us more answers on the relevance of hemodynamic assessment and lung biopsy changes. Oh, I'm already over time. Okay, sorry. So should I actually just stop there? And
can you please conclude?
Yeah, sure. So I just like to say that there is data that exists out there. I'm not going to use my slide. So there are other markers that people seem to be interested in. One is structural markers on things like CT imaging, which looks at pulmonary arterial dilatation, and there's a fractal branching pattern in the pulmonary vasculature. And perhaps using a combination of these two in some form of an indicator, that could be a predictor of long-term reversibility. And then there are functional markers like vascular distensibility using intravascular ultrasound. Again, there are some papers published on that. Then more interestingly, there are molecular markers. So this includes things like circulating epithelial cells and also certain protein markers that seem to go up and down during pulmonary hypertension progression. So whether these could more reliably predict irreversibility, these are all questions that are unanswered, but questions for the future. Now there is also this whole genome sequencing. So you look at the circulating mRNA and try and work out, because a lot of these changes are happening in the local milieu at a genetic or an RNA level. So whether those changes could be a better predictor. So these are all unanswered questions. So I have to use my concluding slide. And there are also various targets of reversibility that people are looking at. So like I started out saying, we say things we said are irreversible have now become more reversible because of the pulmonary vasodilatory agents that we are using. Perhaps in the future, when we target no specific molecular targets, even things we consider irreversible now might be reversible. So, when I was given this rather optimistic target of unraveling reversibility, I hoped that I could finish my talk with a ta-da, but unfortunately, that isn't possible. I think I'm left more, we're all left wondering and with more questions than we set out to answer. And when I tried to unravel, reversibility, I found that the more I tried to unravel, the more there was to unravel. So this is my basic layman's understanding of pulmonary hypertension, reversibility, and I'm open to comments, questions, and insights from experts who are gathered here.